Actually, most of the questions I get when I talk to other lymphedema therapists is about post-operative protocol for managing these patients. So I thought it would be a good topic to discuss. Unfortunately, that's also the topic that has the least amount of research because there's such a wide variation in amongst centers that are doing this type of surgery in the types of protocols they use, surgical protocols. Apart from the surgical debulking, which many of the centers that use surgical debulking follow kind of the gold standard, Hakan-Brorson's protocol. And then it's a very standardized method of managing them post-operatively. For some of the physiologic procedures, it's not so standardized in the approach. The surgical procedure is not standardized, but the approach of post-operative care is also not standardized. So I have no disclosures. So in talking about post-operative management, some of the things really to consider that I'll go over is thinking about the goals of surgery. That's really going to guide your decision-making and treatment expectations post-operatively. I'll talk a little bit about the acute care setting and the timing of outpatient follow-up visits. And we have some of our inpatient team that follow the patients in inpatient. So if there's any questions, I'm happy to have them here answer because some of the issues that we come up against on that inpatient setting are important considerations. And then conservative management, standard of care for conservative management doesn't change too much. Whether your initial approach, a decongestive phase versus the maintenance phase doesn't change too much just because you've intervened with a surgical procedure. Those components of the standard of care still follow through. And then how we deviate from that standard of care, taking in the considerations of the surgical procedures, how we would adapt that and individualize that for the patient. And I'll give you an example of a patient that has gone through some of the surgical procedures so that you can get a glimpse. And then during the breakout sessions, I have some other examples that we can kind of talk through, the measurements in my decision-making for each component. So you saw this diagram. We've all been presenting it because we all follow the same algorithm. And we're going to be talking about patients who have undergone the surgical intervention, and they get sent to lymphatic therapy for we call it the surveillance protocol. So we're going to follow these patients for a minimum of 4 years post-operatively. So managing the lymphedema long-term after the surgical procedure. So, and again, you've seen this before, but it bears looking at it again because the expectations for the outcome really varies. So if we're talking about the surgical debulking or the liposuction procedure, remember the kind of the pros and the cons or the pluses and minuses, we can expect a significant volume difference. Post-operatively, there's a lot of fat removed, and patients wake up with the limb that's the same size as the uninvolved limb. So it's kind of, sometimes they kind of burst into tears when they see it and they, get out of bed for the first time with their limb being so much lighter. So in that respect, it's life-changing. So we can expect to see a significant volume change, and we're going to continue that throughout the post-op management. And also symptom improvement, especially if patients have symptoms of pain or discomfort. After the surgery, they often wake feeling an improvement in their symptoms, and that usually continues to improve post-operatively. And decreased risk of infection. So those are the things that we can expect post-operatively after this procedure when we're seeing the patient. On the downside, it requires compression 24/7. So we would not expect to see a reduction in the amount of compression patients are going to need because they know that up front going into it, the procedure, what kind of compression they're going to need to wear. On the other hand, if it's a physiologic procedure that patients are having, we would expect them post-operatively over time to have a decreased need for therapy. The use of compression, the level of compression, the number of hours of compression, maybe the need for any adjunctive treatments like MLD or compression pumps, or the amount of time and money and effort they spend on compression and controlling their edema, we would expect that to decrease. And then also symptom improvement. Again, especially if somebody's having discomfort, that's one of the first things that they notice post-operatively is that achiness, that discomfort, that heaviness goes away. And another decreased risk of infection. And we would expect only to find a modest volume reduction. So if we're tracking volume over time, that's not going to be one of the metrics that we're expecting to see big changes in over time. So in the acute care setting, that's really where we first come into contact with the patient. If the patient's coming in for a surgical debulking, we follow that protocol, their compression garments, and the compression garment for the upper extremity is a class 2. We use Elvarex garments per Borson's protocol, flat knit, custom made. The dimensions of the sleeve are made based on the uninvolved side. We add some extra centimeter or 2 at the wrist, depending on how much swelling they have in their hand. And we often then use if they do have swelling in the hand, we may take the involved measurements to make the garment initially, and then post-operatively we would reduce that. So it's because the liposuction or the debulking, it's not including any removing any fat hypertrophy in the hand. So that swelling that they have preoperatively is likely to continue post-operatively, and even patients who have post-operative, preoperative, they don't have swelling in the hand, we often see it post-operatively. So we make a generous measurement of the hand in fabricating a garment for post-operative wear. And then we can always refabricate the garment post-operatively if that volume comes down. So the garment for the lower extremity is wearing a waist-high 1.5 leg, class 3, which they wear day and night, and a thigh-high class 2 garment, which is worn during the day only, so they take that off before going to sleep. And the dimensions of that, most of the dimensions are based on the uninvolved limb. The waist measurement is going to be a true measurement. The length measurement is going to be a true measurement. We're going to add 2 centimeters at the Y measurement at the ankle, and then the measurement just above the ankle, we're also going to add a centimeter. Because most of the fat hypertrophy is coming more proximal from that. And that's one of the hardest measurements to get for comfort is around the ankle and foot to make sure it's not uncomfortable for the patient. Remember, they're going to be wearing for daytime hours 2 layers of compression. So think about not only the level of compression, but friction that comes with movement. And one of our first patients post-operatively, I learned my lesson well, was he didn't follow our activity recommendations, or maybe he didn't ask specifically enough whether he could do, he ended up going back onto the golf course, and he felt so good and so light and able to move. He went out into the golf course and several days in a row played several rounds of golf, and really caused some injury to his ankle, the skin around his ankle, because of all that 2 layers of compression with all that friction and all that walking. So we now warn patients not to do any heavy duty exercise, at least for the first 6 weeks. And we make sure that we monitor the skin more carefully in between that time frame. So the garments are donned in the operating room. And if you haven't seen some of the donning tools, we happen to use an easy slide. Which is out at the Job's table, and Dr. Single uses that in the OR to get the garments on, because he's just finished a heavy-duty liposuction procedure, and then he has to muscle on some compression garments, because you can imagine how hard it is for patients to put on. Now they're anesthetized, so it's even harder to get those garments on. So his job isn't done when the surgery is over. He puts the garment on, the patient wakes up with that waist-high garment on. And the garments are changed over the first 2 weeks, again, according to the protocol that was outlined by Borson, every other day. And that's post-operative pain, healing of incisions. There's still quite a bit of discomfort. Changing the garments every day would be, that's the hardest part of the recovery process, I think, for most patients, is learning how to, getting the garments on and off during that post-operative healing period. So while they're in the hospital, and then for the first 2 weeks after surgery, we have them change the garments every other day, so it's not as traumatic over the skin. And they're in the hospital for 3 to 5 days. So our inpatient team sees the patient the day after surgery. It's not going to be a garment change day. They're going to put the thigh-high garment on top of it, and they're going to encourage the patient to get up and walk as much as they can, activity-wise. The day after that is going to be a garment change day, so they'll assist the patients and make sure they're medicated, they're pre-medicated, they assist them up and monitor them as they take the garments off. And allow them to take a shower and then put the garments back on again. And if they can get the garments back on successfully, correctly, and their pain is under good control and everything else is stable, then they could go home. And if there's any problems and they need any kind of management, they're going to stay for another 2 days to have another garment change. And so some of the problems that we've had in that post-operative, that acute period, is quite a bit quite often patients have hypotensive episodes. They're in very heavy-duty compression, sometimes for the first time after being in bed for a large number of hours, and then they go to stand up, take the garments off, they become, the orthostatic hypotension, and so sometimes that's a difficult problem. It takes some intervention with, the whole team to overcome that. And so they've made some changes in the practice of how they interact with patients to try to minimize the effects of that, but that's something to be on the watch for. And then the other thing that they have to really be cognizant of is when they take those garments off, is really making sure they look at the skin. And if patients don't have the garments on or they let them slip down, so that they're not fitting well, then the skin can become irritated or even broken down. So they have to be aware of the skin condition as they're seeing these patients. For the lymphovenous bypass, it's a little bit easier. That post-operative period, they're often seen in the PACU, and the limb is bandaged. There's going to be minimal swelling, some swelling post-operatively, but bandaging, patients will go home with bandaging, and they usually can go right back into their preoperative compression, and we don't make any changes to that preoperative management. As long as they can fit back into the garment, they can continue wearing it. And for the lymph node transplant, patients will be seen, they're followed up for mobility reasons on the inpatient side, but they're out of compression for 3 weeks. So we don't have to do anything with their compression, but as Dr. Single had mentioned, this is a flap, it's got to be protected. So not only do they have no compression, but they're also splinted to prevent any excessive tension, or to limit the range of motion to protect the healing lymph nodes. And then they're hospitalized for about 3 days. So once they follow up an outpatient and they're cleared at the 3-week mark, then we'll resume the compression. So in the acute setting, for the surgical debulking, they're going to be looking at when are they ready to go home, working with the team for discharge planning. They're going to be managing that first shower and the garment changes, and closely monitoring their vital signs in their skin, making sure that the integumentary assessment is done. Outpatient follow-up occurs in the surgery clinic, usually the week after surgery. And because we're co-located, if patients are having any issues with getting the garments back on or skin that we need to be aware of, we're right next door, and we can often kind of take a peek. In therapy, we see the patients for follow-up officially at the 6-week mark to take a first set of measurements, and then 3, 6, 9, and 12 months. And then at the 9-month mark, they'll follow up in the lymphatic medicine clinic, and that's when our nurse practitioner will start the workup for the 1-year follow-up. So for debulking, then we're going to focus on all of those visits on taking measurements of volume for sure. We want to make sure that the volume reduction that was achieved during surgery is maintained, and any subsequent further reduction, which we often see, we accommodate that with compression. So changes in the compression to make sure that the reduction usually continues to reduce, and then it plateaus about month 9. And we want to make sure that we maintain that with compression. So it may be more frequent garment changes in that time period. For somebody with a lymph node transplant, the goal is really to keep the volume stable while hopefully their symptoms and quality of life is improving. And we may begin a controlled wean of their compression, not until after the first year follow-up. So we'll wait for the imaging to see how that looks, and if a patient has remained stable, then we might try a control wean of the compression. And that can take several forms, but reducing one aspect of their compression. For lymph node bypass, again, the goal is to, we would expect to see improvement in symptoms, but we want to maintain that volume, stable volume over time post-operatively. So that's what we're going to be looking at. So if we think about the components of lymphedema therapy, skincare, MLD, compression, and exercise, and kind of take each one separately and think about what we're going to do. They're really, most of the guidelines are silent on specifics of using these different aspects of care post-surgery. The ISL guidelines really call Skin care is one component of the standard of care in phase 1 and phase 2, and ongoing care of patients with lymphedema. Patients postoperatively have some additional needs looking at their skin care. And then also guideline from the APTA, focusing on patients who have breast cancer-related lymphedema. Also, ongoing home programs should include not only self-MLD, but compression exercise I'm sorry, I skipped. There we go, sorry. MLD standard of care in the decongestant phase and ongoing care according to the ISL guidelines and the APTA guidelines for patients with breast cancer-related lymphedema. And compression, ISL guideline goes so far as to say that ongoing care consists primarily of compression to maintain and maximize the reduction of edema. And for the APTA guideline on breast cancer-related lymphedema, individually fitted compression garment and appropriate night compression if indicated, as well as exercise is recommended. And exercise is really also another big black box. Not a lot of detail if we go back to all of the guidelines in the literature, but most of the guidelines really suggest that it's important. So important that there's not very much detail. Ongoing maintenance should include continuation of exercise as needed. So whatever they were doing before, they should continue doing. I would suggest maybe we want to improve that. APTA guidelines for breast cancer-related lymphedema, exercise should be recommended. Compression should be tailored to the patient's individual needs. There should be an individualized exercise program for both aerobic and resistive exercise components, so that's important. The resistive exercise, it's the first time we're starting to see resistive exercises recommended. And sequential proximal to distal exercises incorporating diaphragmatic breathing, also recommended, and compression use with exercise may be beneficial. I would say most of our patients, if they're wearing compression, especially if they're wearing it day and night, are going to be using it when they exercise especially. So for our patients, that's definitely recommended. And then for patients with breast cancer, exercise is considered safe, no adverse effects, but insufficient evidence to recommend any dose-specific recommendations. But they do have some dose-specific recommendations for resistive exercises. 2 to 3 times a week, 60 to 75% of 1 repetition max, or using a 15 RPE. For intensity, 1 to 3 sets of 8 to 15 repetitions, starting off low and progressing slowly. So that would be the same recommendations that most guidelines would suggest for anybody with a chronic disease. And again, the U.S. Department of Health and Human Services activity guidelines do recommend for any patients with chronic diseases or conditions at least 150 to 300 minutes of moderate intensity exercise and strengthening exercises at least at a moderate level on 2 or more days per week. So we don't really have a lot of specifics to fall back on as far as each specific surgical intervention. So let's see how we would take each of the aspects of care and adjust them for our patients. Skin care, most important, after somebody with a lymph node transplant, we're going to be monitoring the incision as it heals. They're following up in the surgical clinic, and then they may be followed up in the lymphatic clinic, the lymphatic therapy clinic. So we're going to have eyes on that incision over a longer period of time. So we'd want to be alert to anything that needs further further consideration. MLD we would usually put on hold for a couple of reasons and postoperatively, because we want to wait until that lymph node, the incision is healed, till the skin is healed, till the pain is under good control, and really want to see how their volume is managed over time before we start adding MLD. And if we start to add MLD on top of that for patients who are doing self-MLD before their surgery, we would want to wait and maybe change the pattern of drainage. So based on our knowledge of what their ICG, which was included in their preoperative workup, what pattern of drainage is going to be best for them, and then considering now there's a new lymph node placed distally in the forearm, we may then direct fluid, if they're doing self-MLD, towards that new lymph node, as opposed to a more proximal orientation of the MLD. So that really has to be individualized based on the location of the new lymph node and the ICG workup information. Compression, no compression at all for the first 3 weeks. while that is healing, and then once they're cleared in the lymphatic surgery clinic to begin compression, we would expect them to go back into the same preoperative compression they were using before. And although you would think if they've been out of compression for 3 weeks, it would be hard to get them back into their compression, we find that they don't have as much swelling as you would expect. They have a new lymph node in there. It might not be working at its full potential, but patients are also encouraged to use elevation in those first 3 weeks when they're not up and using their arm. And they're using their arm for active movements. So we don't see as much swelling as you would expect. If somebody has enough swelling that they don't fit back into their preoperative garment, then we would bandage them. And sometimes it would take maybe 24 to 48 hours. So when recommending patients the replacement of their garments, I'm always thinking about the timing of the surgery, and I don't want them going into a surgery with a brand new garment. I don't want them going into surgery with an old garment that needs to be replaced too quickly. So, ideally 2 months before surgery, if that's when they replace their garment, or 3 months. So I know that they're used to it, but it's not so old that they can't go another couple of months after the surgery. So that would be the best timing. And then once we get to the 3-month mark after surgery, then we could get a new garment made for them if the dimensions, the volume changes at all. And then for exercise, we're limiting their range of motion somewhat in the immediate postoperative period, but once they return home, they can start to do most of their normal activities. No heavy lifting, no heavy exercise. They've had a vascular repair, so we're going to ask them to refrain from heavy-duty exercise for at least 6 weeks postoperatively. And then after that period, resume normal exercise. And when I say normal exercise, we've started to record how many minutes of exercise somebody's doing per week, and we've added another dimension on our documentation, what kind of exercise, aerobic versus resistive exercises. So we would recommend that they do at least 150 minutes a week of a total exercise, and then also some strengthening or resistive exercises. And if somebody's not already doing that, we will give them a resistive exercise program using some TheraBand for the upper or lower extremity, depending on the body part that was involved. So we're going to resume post-op compression at 3 weeks, follow up at 6 weeks, 3 months, 6 months, 9 months, and 12 months. And at those measurements, those visits, we're going to measure volume, bioimpedance, quality of life, and patient symptoms. We're going to make sure that we assess skin, the garment fit and their usage, and then plan for garment replacement, what that time frame is going to be. So expectations then at the 6-week mark. After somebody's had a lymph node transplant, remember, the expectation is not for a huge reduction in volume, so I'm going to expect that the volume stays steady. I would be worried if we start to see increasing volume. We might need to make some changes in their management program, but otherwise, no change is a good sign to me. So we want to keep that stable. And I would expect the bioimpedance at some point may come down. We would usually see this trending downward because that's going to be a representative marker of how much extracellular fluid they have. And I would expect after a lymph node transplant over time, that's going to come down. So I'd be looking for that to be reduced. If I start to see that going up, I'm going to have to make some adjustments to that postoperative management schedule. And then assessing skin and the garment fit really has to do with how well it fits and when we need to replace it, making sure there's no skin chafing and that they know how to put it on and off correctly. And then at 3, 6, and 9 months, again, we want to see that volume stay steady. And if we start to see it ticking up a little bit, we need to make some changes in either the compression or their activity program, exercise program. It's not always about the compression. It might be that they need to add more frequent exercise sessions during the day or the week to help manage that. And then after a lymph node bypass, a lymphovenous bypass, skin care, MLD, also we're going to put this on hold after the surgical procedure and wait till their volume stabilizes before we have them resume any kind of MLD. And not that it's contraindicated, it's just that I would want to get the compression and their activity level straightened out first and see what the effective is on their volume before I start having them resume the MLD. They're resuming preoperative compression immediately. So again, timing of that garment, same with the lymph node transplant. I don't want them going into the surgery with a brand new garment, but I don't want it to be so old that it has to be replaced too soon. So a mid-range garment. And then exercise, resuming normal activity and no vigorous exercise for 6 weeks. And then they would resume a normal exercise program. And the follow-up, same. We're going to follow all of our patients at the same intervals, 6 weeks, 3 months, 6 months, 9 months, 12 months, unless they need some treatment in the interim. We need to make some more frequent changes. I'm doing the same measurements on every patient, assessing the skin, and then making a plan for the garment. And again, I'm asking myself, what are the expectations for the measurements? I want the volume to remain fairly steady, if not decreased. I don't want to see it increase. I would expect the bioimpedance to be reduced over time, slowly, and then we would need to have the garments replaced at least every 6 months, if not 4 to 6 months, on a regular basis. We may expect over time then to reduce the need for compression, and I'll talk about that in the breakout session, how we would kind of titrate the reduction of the compression over time. And the liposuction, we talked a little bit about the protocol for this. We follow Borson's protocol, and it's well described in many of his publications, and the most recent one where he talks about his compression protocol, the amount of the class 3 and class 2 garments for the lower extremity and class 2 for the upper extremity flat knit. And he would reduce the compression, or he'd reduce the circumference of the compression or increase the class of compression postoperatively to maintain the best reduction in volume. So if a patient comes out of surgery with a 0% difference between volume, we want to see that go into the negative numbers over the succeeding months, and then it will level off at about the 9-month mark, just before they come up with their first year follow-up. And if not, we're going to make some changes in the garment. So we might reduce the circumference, we might increase the class of compression, we might increase the frequency of changing the garment, or we might add another layer of compression in order to keep the volume reducing to match pace. Remember, after somebody's had the surgical debulking, all of the difference in the volume is now going to be fluid, because the fat hypertrophy is gone. So if we start to see any increase in volume, that's all fluid, and our main way to treat that is going to be adding more compression. And so the same follow-ups that we do with all of the other procedures at the same intervals, and the expectation is not only are we going to preserve the reduction in volume, but we want to see more a reduction in volume beyond that, and again, peaking at about the 9-month mark, and reduction in symptoms and improvement in quality of life. And I'm just going to show you one example of a patient who came in with, on the photo on the left, with left lower extremity lymphedema. Workup found to had fluid, and you can kind of see that if we were going to pit this, he would have some pitting edema. So he actually needed a course of therapy, and came down to I think about 63% difference before he went into surgery, from some preoperative care. And his LDEX was 116.6, and his quality of life was 61, and that goes on a scale from 26 to 104, so significant. 2 years post-debulking, his volume was down to 10%, his LDEX was down to 36.2, and his quality of life, 38. So you can see, I don't know if you can see in the picture in the middle, he's having a little bit of difficulty at the top of his inner thigh. You can see that kind of bulge there. And some of that comes from not being able to pull, or not pulling that garment up so that the seam is right along the inguinal crease. And if he doesn't get a good fit there, it's allowing some bulge. So we'd have to do some work with adding some textured compression or some foam inside there, and sometimes even bandaging on top of that garment overnight so that he gets good compression to reduce that. And then you can see 2 years after he had a lymph node transplant, his volume was 13%, so slightly up. His LDEX is down to 29.4, his quality of life is improved to 27, and he doesn't need to wear 2 layers of garment to maintain that. And he's actually shown further reduction beyond this, but he's down to a thigh-high garment. 1 layer, it's a 3 forte, instead of wearing the 2 layers of class 3 and a class 2 after having a lymph node transplant. And lower extremities are harder. The reduction in volume after lymph node transplant is a little bit slower, so we're reducing the compression a little bit more carefully. But he's quite pleased with his results. Any questions? So the question was, have we seen anybody with bilateral involvement, and how we would measure for the Garmin's pre-debulking? You know, first time that happened, I wasn't sure what to do. I called our radiologist, and Leo, and he pulled up, and I said, what size should I make this garment? How much fat is there that's going to come out? And so he talked me through how many centimeters at each point along the calf, and he kind of used the MRI to show me what to do. So we took the true kind of waist measurements and length measurements and ankle, and then I estimated the reduction based on the MRI results. And actually, we had a very good fit. So I go back to the radiologist all the time to estimate that. One more question?
Have you seen any post-op infections, especially people that already had a lot of issues with cellulitis after the debulking?
We have seen some patients who, after debulking, especially if they've had cellulitis pre-debulking, overall we've seen a decrease in the incidence of infections in patients after debulking, but there are some patients still who would have an episode of cellulitis. And Drew, you might be able to answer this. I don't know if you have any other numbers at hand?
Yep, so I'd say exactly what you said. So when we've studied this, the incidence is lower after debulking. We've had 2 cases I know of post-op cellulitis that were related likely to injuries that occurred to the extremity post-operatively. One was a kitchen oil burn where the individual was cooking, oil went on to the extremity, and then they developed an infection. And the other thing was actually related to a pressure sore, not like a stage 1 pressure sore on the extremity.